Hi, this is Andy Turnbull from the Royal Bournemouth Hospital and Optegra, and this lecture will provide an update on biometry and IOL calculations. So over the next half an hour or so, we'll go over some of the latest developments and also just highlight a few things of importance that may or may not be well known or understood. So according to Doug Koch's paper in 2017, most surgeons hit the refractive target in around 76 to 80% of cases, that is within plus minus half a diopter of target. A minority of surgeons do better and are in the 90% plus range. And this might sound impressive, but even this means that 1 in 10 patients will miss the target by more than half a diopter, so there is still work to be done. With newer methods, newer formulae, newer machines, 90% within half a diopter of target is achievable by most surgeons. And really the only thing that is stopping us reaching this level is our own attention to detail, and it's important that we pay close attention to things like biometry, IOL selection, and obviously surgical technique. Nonetheless, technology is imperfect, and with currently available IOL models and biometry, 92% is considered the ceiling really of what we can achieve. In the future, with more accurate IOL production with tighter tolerances and improved biometry and formulae, it may be that we can more comfortably achieve the 95% mark. As a final point, our refractive accuracy is completely at the mercy of whoever is refracting postoperatively. The ideal is to have someone who is both accurate and honest, someone who will tell you exactly what the patient's refraction is without trying to please you by saying everyone is plano. So we'll now look at some of the recent advances in biometry devices. So over the last few years, we've seen great progress in the quality and versatility of biometry machines. Companies have improved acquisition time, the accuracy of keratometry, the ability to measure axial length even in dense cataracts, which has meant less reliance on A scans, and also given us the ability to measure a greater range of parameters with which some new formulae are making good use of. Some machines have other features which may facilitate things like toric or refractive surgical planning. So the machines that we have employ a range of different techniques to achieve accurate biometry. Partial coherence interferometry was the original and used with much success by the IOLMASTER 500. Optical low coherence reflectometry is a similar principle used by the LENSTAR amongst others. And swept source OCT is the latest technology to enter the domain. And this can be considered the gold standard nowadays for biometry. And this is used by the latest IOLMASTER, the 700, and also the Argos from Movu. So just a bit more detail on first the LENSTAR and then the latest IOLMASTER. So optical low coherence reflectometry, as used by the LENSTAR, is a similar principle to time domain OCT. The LENSTAR offers more accurate keratometry than the previous version of the IOLMASTER, as it takes measurements from a greater number of points on the cornea. It's also better at getting through dense cataract, although not quite as good as the latest IOLMASTER. Both Tom Olsen and Warren Hill have licensed their formulae to HAAG STREIT, which now come built in on the LENSTAR. And it also has an optional add-on called the T-cone, which provides topography. And this is used to facilitate toric planning. Now, while this sounds very attractive, it actually means that when it comes to toric planning, you're sacrificing the excellent keratometry that the LENSTAR provides and making way for the topography output, which actually isn't quite as good as other purpose-built topographers that are on the market. So I think if you're taking toric planning seriously, it's worth using the LENSTAR but then having a separate purpose-built topographer rather than using the T-cone. That's just my opinion. The latest IOLMASTER, the 700, is based on swept source OCT, as we said, and this involves a superluminescent diode light source that sweeps to and fro. This is faster and more precise than traditional OCT, with a speed of 2000 A scans per second and a resolution of just 22 microns. It provides a comprehensive measurement of the eye with multiple parameters, including the posterior cornea, total corneal power, and also a full-length OCT cross-section of the eye, which can be used to assess things like lens tilt, adequate fixation, and also screen for macular pathology. It can often manage to image dense or posterior subcapsular cataracts, which the IOLMASTER 500 or the LENSTAR would struggle with. And as well as improving axial length measurements, keratometry is also better due to a much larger sampling area. So on the subject of total keratometry, or TK, this is a new parameter provided by the IOLMASTER 700, and it takes the anterior and posterior Ks as well as corneal thickness to estimate the overall power of the cornea. This can be used in older formulae such as the HAAG or the SRKT or the Holiday to improve accuracy, but it shouldn't be used in certainly not the original BARRETT formulae, as these already include a theoretical prediction of the posterior cornea's contribution. So if you were to use TK with the normal BARRETT formulae, you'd actually be correcting for the posterior cornea twice and you'd end up with the wrong answer. So to get around this, ZEISS have launched a couple of BARRETT TK formulae that can be used with the TK values. The other thing to just be aware of is that you mustn't confuse TK with TrueK, which is BARRETT's post-refractive formula. They are entirely separate entities. But is measuring the posterior cornea useful? And it certainly sounds like it should be. But what we need to remember is that modern formulae like the BARRETT and the Olsen already take the posterior cornea into account by predicting its contribution based on sophisticated theoretical models. Now, these predictions are extremely good, and so far no significant advantage has been found with using the measured posterior cornea in normal eyes. Now, this table is from Fabian and Wehner's study and shows that there's only a marginal gain to be had with TK in most cases. So the HAAG goes from 77% within half a diopter to 79%, and the BARRETT goes from 84% to 86% when using the BARRETT TK formulae. So it's a marginal gain. If you have it, then by all means use it, but it's not the be-all and end-all. However, in unusual eyes, the predictions start to fall down, and it may be that measuring the posterior cornea is beneficial in such cases. We'll talk more about that a bit later on. I think the bottom line is that it's a great development, it's a nice tool to have at our disposal, and I think it will become more and more useful as we progress. So although biometry devices have improved significantly in their scope and precision, the machines are still very much dependent on the user for accurate results and interpretation. The output needs to be reviewed critically to avoid errors, and this is where biometry validation comes in. So to assist with this, validation checklists have been developed by Warren Hill for both the LENSTAR and the IOLMASTER, and these are akin to pre-flight checks in the aviation industry. And these are particularly useful when delegating work to technicians who may not have the insight or awareness to spot dodgy or inconsistent readings. And it's worth having these printed out next to your biometry machines as a prompt. So having measured the eye, we need to synthesize the data into an IOL power calculation. We have lots of options here and it can get quite confusing, so I'll try and provide some clarity over the next few slides. So firstly, a mention about formula classification. So this, published by Doug Koch et al. In the JCRS in 2017, replaces the old terminology of first, second and third generation formulae, which you'll often hear people talking about. So most of the early attempts, the historical and refraction-based regression formulae, are now obsolete and of historical interest only. Vergence formulae are the most widespread, and these are based on the optics of the Gaussian model eye, and these can be subclassified according to how many variables they require. The next category is ray tracing, of which the Olsen is the most well known, and the Olsen formula uses ray tracing to look at asphericity and other aberrations of both the eye and the IOL. Formulae based on Gaussian optics provide more of an average of these variables, and that's where the Olsen may potentially have some value. Finally, we have artificial intelligence, which is the newest category and is employed by the Hill RBF and the KANE formulae, amongst some others. So this classification is certainly an improvement and more accurately describes what each formula does and how they differ, but it's not without its faults. Some of the modern formulae, such as the BARRETT and the Olsen, are actually hybrids and straddle different categories with elements of AI, data-driven enhancements, and or ray tracing. But nonetheless, it's still a more useful classification than referring to different generations of formulae. So before we delve into the specifics of some of the formulae, this chart is from a recently published study of 13,000 eyes from Kaiser Permanente, and it shows the relative accuracy of currently available formulae. As you can see, even the best performing formulae using the very latest methods still don't achieve anything like 100% within half a diopter of target, but there are a few options here that enable you to easily break the barrier of 80%. So the reason for this inaccuracy is that all methods are limited by their prediction of the effective lens position, the ELP. So the ELP is the IOL's final resting place and has a significant bearing on the refractive outcome, but it can't be measured preoperatively. So accurate preoperative determination of the postoperative ELP is really the holy grail of IOL formulae, and this is what methods using artificial intelligence and pattern recognition aim to achieve. The older two-variable formulae, such as the SRKT and the Holiday 1, are based on thin lens optics, and they manage to estimate ELP reasonably well in normal average eyes, but the predictions weaken in more unusual eyes, such as longer eyes and particularly shorter eyes. Newer formulae use additional parameters and or thick lens optics to try and improve ELP prediction, and anterior chamber depth and lens thickness appear to be the key determinants of where the lens will sit in the eye. This is because the relationship between axial length and ACD is non-linear, so one cannot be accurately predicted from the other, certainly not in all eyes. For example, not all big eyes have deep ACs, and not all small eyes have shallow ACs. So these formulae all take into account the non-linear relationship between axial length and ACD, which makes them potentially more suitable for atypical eyes, as well as being very accurate in normal eyes. So this table doesn't include the artificial intelligence methods like Hill and KANE, which handle unusual eyes in a different way by interpolating data from past experience. So most formulae do pretty well with normal eyes, but long and short eyes have always been more difficult to get right. And it's these cases that usually reduce the overall accuracy of a given formula and equally will reduce your overall percentage of eyes within half a diopter of target. So the difficulty with long eyes is the accurate measurement of axial length. Optical biometers rely on average refractive index for the eye in order to calculate axial length. But in long eyes, this average refractive index is no longer accurate due to an increased optical path length through the vitreous. So this means that the axial length for long eyes is often overestimated, leading to an underpowered IOL being selected and a hyperopic surprise. There are several options to try and get around this problem. The WANG-KOCH method provides a way of adjusting the axial length to give a lower reading, compensating for the overestimate provided by optical biometry. We'll talk about that more on the next slide, but it should only be used in certain formulae, as some more advanced modern formulae can handle long eyes without this adjustment, and that's the approach that I would recommend. Another option is to use a biometer that provides segmental axial length measurements, i.e. one that takes into account the increased vitreous volume in larger eyes by applying a different refractive index to each segment of axial length. This can work well with older formulae like SRKT, but again should be used with caution with the latest formulae, which have been intrinsically designed to cope with long eyes. So just a bit more about the WANG-KOCH, as it's something that people do talk about quite a bit. Essentially, it adjusts the measured axial length by a coefficient specific to a particular formula, and this leads to a reduced axial length that is then inputted to the IOL formula. The formula-specific coefficients are available on both Warren Hill's website and in the most recent paper by Li Wang and Doug Koch. It was designed for use in the older Virgins formulae and is more aggressive than formulae that include a built-in solution for long eyes. So this means that it's very good at avoiding hyperopic outcomes, but it does increase the risk of leaving patients more myopic than you would desire. The original paper describing this technique used the manufacturer's A constants and refractions performed in a 3-meter refracting lane. So Lee, Wang and Doug Koch have recently updated their recommendations based on the ULIB constants and a standardized 6-meter lane, and have found that adjustment is not required for HAAGis. The Holiday 2 formula has also recently been updated and no longer needs adjustment in long eyes. And finally, the WK adjustment should also not be used with formulae that are already designed to cope with long eyes, and they are not applicable after corneal refractive surgery. So a better option, in my opinion, is to use the formulae that already account for long eyes. These are fundamentally more accurate and also avoid the need for complex calculations or of adjusted axial lengths, which obviously creates a risk of transcription errors. So as I said at the start, most formulae perform well at an average axial length of around 23 to 24 millimeters. But as axial length increases, you can really see here how formula performance diverges. So again, this data is from the large Kaiser Permanente database study published in 2018 and shows that the best options in long eyes are the Olsen, Barrett and HAAGis without WK adjustment. So we've got the Barrett here in red, HAAGis here in yellow, and then the Olsen in purple. You can see that HAAGis with the WK adjustment is actually right down here. Since this study was published, the Holiday 2 has been updated and improved, and also it doesn't include any of the newer options such as the Hill and the KANE formulae. So we've got a few good options for long eyes, but short eyes continue to pose a challenge. Measurement errors or imprecision with ELP prediction have a much greater impact in short eyes than they do in normal or long eyes. And this is because we're implanting higher powered IOLs for which small deviations in the ELP have more of an effect on postoperative refraction than they would with a lower powered lens. Anterior chamber depth is an important parameter in all the modern formulae to predict the ELP, but with short eyes it's difficult to know whether the anterior chamber depth that we're measuring is an anatomical feature of the eye or whether it's being influenced by the increasing thickness of the lens. And this is where measuring lens thickness and also white to white can help. But even still, short eyes continue to cause the greatest problems to IOL calculation methods. Fortunately, the really short eyes are also quite uncommon. So the traditional adage has been less than 22 HAAG, but the latest evidence suggests that this is not actually the best option for short eyes, and this is contrary to the current NICE guidance in the UK. So a few years ago, a couple of studies came out which showed that HAAG was better in short eyes than some of the older versions formulae such as the SRKT, but these studies have since been superseded, and the latest big studies have shown that in fact HAAG is one of the poorest performing in short eyes, and options like the Barrett and even the Holiday 1 do better. So for these short eyes, I'd recommend looking at the Barrett, the Hill RBF or the KANE, all of which have been shown in recent studies to perform pretty well in short eyes, although none are perfect. And just to hammer home that point about the HAAG, here's a quote from Warren Hill a couple of years ago, which just highlights that point. So these graphs are again from the Kaiser study and show that as well as with varying axial length, we also see differences with formula performance with differences in ACD and mean keratometry. So the Barrett formula, which is represented by the red line, again seems to retain the greatest consistency across all of these variables, whereas all the other formulae become less accurate in some not uncommon scenarios. So based on this, really the Barrett can be used quite comfortably for all eyes, and this means that we don't have to worry about chopping and changing formulae based on the biometry. The only thing to bear in mind is that for really short eyes, those less than 21 millimeters, no formulae perform brilliantly well. So patients should be advised regarding the higher risk than usual of a refractive surprise. So I've spoken about several formulae, including some new options. And while it's great that so many people are actively working to improve our outcomes, the numerous options can lead to confusion. So in this section, I'll just give a bit more detail on the three that I think are the most useful in everyday practice, partly because of their accuracy across all types of eyes, but also because they're all freely available online. So firstly, the Barrett Universal, now the Barrett Universal 2, was originally designed in the early 1980s when Graham Barrett was developing the first foldable IOLs. The formula has been continuously updated and improved since then, and as you can see here, it's more than just a formula. Whereas other versions formulae such as the HAAG and SRKT involve a single line of computer code, the Barrett can be anything from 750 to 3,000 lines of code depending on the eye in question and the parameters that are inputted. It's a hybrid formula based on Gaussian thick lens optics primarily, but also with elements of paraxial ray tracing and AI, and it uses up to 5 parameters to provide accuracy across the whole range of axial length. The universal formula forms the basis for several other calculators, such as the toric calculator, the post-refractive true K formula, and the RX calculator, which is for IOL exchange and piggyback lenses. So this essentially makes up a one-stop shop for all IOL calculation situations. And according to Warren Hill a couple of years ago, the Barrett is considered the best theoretical formula currently available. So a question often posed is, what do I do if I've only got an IOLMASTER 500 and I can't measure all these new parameters like lens thickness and white to white? Is there any point in me using the Barrett formula? Well, the simple answer to that question is yes, you should. Here's some evidence to show why. So this is from a series of almost 300 consecutive eyes. And it shows that if you just use axial length and keratometry, the Barrett already outperforms the Holiday 1, the SRKT, and the HAAG. If you add anterior chamber depth, then the difference is even greater, and it performs similarly to the HAAG. If you add further parameters such as the lens thickness and then the white to white, this elevates the outcomes even further. So even if you only have an older biometer, you're still better off using a formula such as the Barrett or the HAAG than the SRKT, Holiday 1 or HAAG. So over the last few years, the Barrett has consistently come out on top of the pile in studies comparing formula performance, and it works well for all types of eyes as we've seen, including being more user-friendly and accurate than the WANG-KOCH adjustment for long eyes, and one of the best options for short eyes. However, there aren't many studies so far comparing the Barrett with the latest version of the Hill RBF or the KANE formulae. The Hill RBF is a method rather than a formula. It's an artificial intelligence algorithm developed by Warren Hill and a large team of mathematicians and computer programmers. RBF stands for radial basis function, which is a mathematical model that combines pattern recognition and data interpolation, and it's also used in things like facial recognition software and fingerprint scanning, financial forecasting in the stock markets, and so on. The advantage of RBF and AI is that it can generate knowledge in situations that have not previously been encountered, whereas formulae become inaccurate when the model they're based on no longer fits. It doesn't rely on any of the usual optical principles of other formulas, so it's an entirely different method to anything else that's gone before. And just as an aside, this is one of the intriguing things, is that it's such a different method, and yet the outcomes have been shown to be almost equivalent to things like the Barrett or the KANE formulae. So what we're seeing is a real convergence of approaches, and hopefully almost getting to the correct answer in the vast majority of cases. The Hill RBF requires 4 parameters: the desired postoperative refraction, axial lengths, Ks and ACD. Initial development of the method investigated 13 parameters, including pupil size, pachymetry, white to white, and so on, but the 4-factor model actually gave the best overall accuracy, and adding more parameters reduced the accuracy rather than improved things further. The method is self-validating, meaning it gives the user an indication of how confident it is. If the result is deemed out of bounds, this means that there was insufficient data paralleling your case to support the IOL prediction, at the 90% accuracy level, whereas conversely an inbounds result means you can be 90% certain that you'll be within plus minus half diopter of target. The method was initially limited by lots of eyes, particularly the more unusual ones, returning out of bounds responses, but this is improving as more data is accumulated. So the HIL database is steadily increasing and thus becoming more and more accurate. The HIL 3.0 is due to be released soon, and this will have around 20,000 eyes. The method was used for 300,000 cases in 2018, and in a study of 459 cases with inbound results, 91% were within half a diopter of target, which is exactly what the maths would predict. Further database expansion is expected to increase accuracy to 94%, and there's also the potential to introduce other algorithms, for example based on ethnicity, to improve accuracy further. But we also have a new kid on the block. So at the time of writing, Jack KANE is a senior registrar in Melbourne and has developed his own formula based on theoretical optics, regression and artificial intelligence. It uses familiar parameters, and evidence suggests that it can be applied to all axial lengths and may be better than other formulae. There is a KANE toric calculator in development, but it's not currently suitable for post-refractive cases. This paper is in press currently in the JCRS and reports the outcomes from a retrospective EPR study of 10,930 eyes from the UK NHS. The KANE was found to be the most accurate, both overall and also in the short and long axial length subgroups. The HIL 2.0, the Ulster, the updated Holiday 2 with built-in axial length adjustment, and BARRETT Universal 2 all performed similarly well. However, the outcomes generally were poorer than those in other similar publications. It's important to note that in this study only axial length K and ACD were used as parameters, and formulae such as the KANE, the BARRETT and the Ulster, and also the Holiday 2 are known to perform better when more variables are inputted, so particularly in the more unusual eyes, where factors like lens thickness plays a more important role in determining ELP. But nonetheless, this study is interesting and of value to those surgeons who don't yet have access to biometers that measure these extra parameters. This recently published study from Kaiser Permanente, this is an update on the previous paper, is possibly the best evidence we have currently for what formulae to use. Similar to the NHS study, the KANE performed the best, with 83% within plus minus a half diopter of target, and the lowest absolute error and standard deviation of all formulae. The emmetropia verifying optical formula, the EVO, which was designed by one of Barrett's ex-fellows, was almost identical to the BARRETT in normal eyes, but its performance dipped with short and long axial lengths. The KANE, the Ulster and the BARRETT all performed similarly well across all axial lengths. So what is great about this is that we can really abandon this archaic practice of trying to select or modify a formula according to patient's axial length. Trying to do this just makes the process less efficient and, more importantly, less accurate. So my preference is still to use the BARRETT suite of formulae because of the integrated toric calculator, which is still considered the best in class, as well as the post-refractive option, which we'll look at in a subsequent lecture. But it is sometimes nice to have one or two others to compare it to, particularly in the more unusual cases of extreme axial lengths. The KANE is also not yet built into any biometry machines, but I'm sure that that will change in the very near future. So that concludes the bulk of this lecture, but I just wanted to finish off with a couple of other things that might help you elevate your refractive outcomes even further. So I'm just going to briefly mention how we approach IOL calculations for SULCUS implantation, as this can cause confusion, especially in the context of having had a complication and needing to switch to a plan B. So the key thing is that an IOL in the SULCUS has a different ELP to one in the bag, and therefore the IOL power often needs to be adjusted. The second thing is that the IOL model that you put in the SULCUS is likely to be different to the one you were planning for the bag, and different IOL models have different A constants. So firstly, the IOL calculation needs to be repeated with the correct A constant to work out what power of 3-piece IOL would be required in the bag. And then, depending on the result, the IOL power needs to be reduced for SULCUS implantation. The amount of reduction is more with higher powered lenses, and Warren Hill has worked out the details of this, and there's a full chart available on his website. and it's worth having this printed out in theatre for reference. A final important thing to be aware of is that if you're planning optic capture, then no adjustment for sulcus implantation is required, because the ELP for optic capture is almost equivalent to the ELP of in the bag. Finally, I just wanted to summarise the process of second eye refinement, which is essentially using the error from the first eye to improve the outcome of the second. So, despite all our best efforts and continuing improvements, refractive surprises still happen occasionally. So when the first eye has suffered a refractive surprise, what do we do to prepare for the second eye? Well, of course, we would run all the usual checks, making sure that the biometry was accurate, checking that the correct IOL was chosen and implanted, having a look at the topography, and making sure there are no other sources of potential errors, such as the patient had previous LASIK and we didn't know. But assuming no other sources of error, the problem lies with imperfect ELP prediction, or in other words, formula error. So several studies have shown that when a patient's eyes are fairly symmetrical, the first eye outcome can be used to refine the second eye IOL selection. Current advice, including in the NICE guidance, is to use a 50% adjustment factor, for example aiming for half a diopter more myopic if the first eye ended up 1 diopter hyperopic. So we recently completed a study looking at this in more detail. So in this study, we wanted to explore whether 50% is the optimum adjustment factor, or whether different factors should be applied to different formulae. So we retrospectively analysed 2 heterogeneous series of consecutive patients, 139 from Australia, operated on by one surgeon, Professor Barrett, and 605 from the UK, operated on by many different surgeons, including those in training. The predicted postoperative refraction and prediction error for each eye was calculated with 4 formulae: the Barrett Universal 2, the Hoffer-Q, Holiday 1 and the SRKT. We used the correlation between the first and the second eye prediction errors in the Australian series to derive an adjustment coefficient for each formula that could then be applied to the second eye's predicted postoperative refraction. We then applied these coefficients to the Australian second eyes and compared the results with the achieved postoperative refraction, and then repeated this process with the UK second eyes, testing for both internal and external validity. So what we found is that with every formula across both series, there was a reduced mean absolute error and an increased percentage of patients within each refractive bracket. The adjustment coefficients used were around 0.5, 50%, which corroborates the work of previous authors, except for the Barrett, which was lower at 0.3. You can see with the SRKT and the Holiday 1, if we use this method, we can increase the percentage of patients achieving within half a diopter of target by around 5 or 6%. The improvement was more modest with the Barrett formula, and this is really due to it being a fundamentally more accurate formula in the first place, but there was still benefit to be had. So our recommendation based on this would be to use an adjustment coefficient of 0.3 or 30% for the Barrett and approximately 0.5 for other formulae. If we're doing this, we ideally need to wait around 4 weeks for refractive stability to occur, and we should also be cautious when there's poor interocular symmetry. This excerpt from the paper just shows how this is done in practice. So if the first eye has suffered a hyperopic prediction error of 1.5 diopters using the Barrett formula, this prediction error multiplied by 0.3 gives 0.45 diopters. So when calculating the IOL power for the second eye, this value of 0.45 should be added to the outcome that the formula predicts. So if the formula is predicting emmetropia, the likely refractive outcome is more like plus 0.45. So to achieve emmetropia, a lens should be selected that the formula says will give an outcome of around minus 0.45. So just to recap, 70 to 80% within half a diopter of target is okay, but we can do better, and as refractive cataract surgeons we should do better. There is, however, a ceiling of accuracy of around 90 to 92% with currently available methods. Swept source OCT is currently the best we have available, but measurements of living dynamic tissue will never be 100% accurate, and the healing process post-operatively also cannot be predicted perfectly. Measuring the posterior cornea and generating total keratometry is great for unusual eyes, but has minimal advantage in normal eyes at the time of writing. Validation checklists are useful and should be encouraged, and we can abandon the practice of using different formulae for different types of eyes, as we now have several excellent options that work well across the whole range. I'd recommend choosing one as your standard, and then only consult the others when you have a particularly challenging case. SULCUS implantation requires some subtle adjustments for the best accuracy, and using the outcome of the first eye to refine the second eye can also elevate your outcomes. So as you can see, this is a rapidly evolving field, and again, as refractive cataract surgeons, we need to make sure we stay up to date with developments. These are the references, and thank you very much for your attention.